Okay, let's talk about our patient today. Our patient today is a dentist. Young lady, a preeminent lecturer, a dental hygienist from Bulgaria, Buffalo, New York, Atlanta, Oklahoma, Vancouver, Canada, Boston, Kansas City, San Francisco, Montreal, Munich, Germany, London, and Santa Maria, California. And we're going to place 14 Lumineers, 8 Lumineers, 10 Lumineers, 6 Lumineers, 10, 2, 8, 8, 10, 10, 8, 10, 8 Lumineers today on our patient. And now we're not treating teeth anymore. We're treating smiles. Isn't that beautiful? So let's look at the transformation from where we started and where we are. Our patient today is an example of that. I'd like to welcome you to a presentation of placing Lumineers on a patient who would like to have a more attractive smile. This is a tray setup that Lisa has, so let's take a look at that if you can get it from the top up there. At first you look at it and you say, wow, that's a bunch of stuff, but if you drew circles around it, it's only 4 or 5 groupings of things. And it's surface preparation, it's materials to bond, and then it's finishing, and then it's checking occlusion, and then we let the patient look back and we look at the overall aesthetic result. So the thing that everything comes together with is that Lumineers Placement Kit that's right behind me there. We put porcelain conditioner on the porcelain veneer. Lisa's already done that. That is citric acid. That's an organic acid. Now don't ever use a inorganic acid. What's an inorganic acid? Phosphoric acid. That's for enamel. But organic acid you put on the porcelain, not because you're going to dissolve anything, but it's going to activate the serenade prime. Never buy these pre-hydrolyzed silane systems because they all react with one themselves and they get fewer reaction sites and they lose their potency with time. The serenade prime will probably be just as good 10 years from now as it is today. And you activate it just before you place it on the teeth. So those 2 solutions have been put on the porcelain. She's polished his teeth with porcelain polishing paste. The reason we do that instead of pumice is plaque is made of grease. And in the porcelain polishing paste is an enzyme, the papase. And that helps act as a detergent to get that off the teeth. So when you etch them, you're going to be really on the enamel. I'm working on this patient without anesthetic, and I would never let anyone work on me with or without anesthetic that wasn't using 4 power or more, because I'm going to have control. See, visually, I'm going to be this close to the surface I'm working on. Visually. I'll be this far away from the patient physically. So when I'm going in the interproximals and removing the Ultrabond, I can really see what I'm doing. And finishing and removing the Ultrabond and the materials is essential to having these things turn out right. So I stress that you get 4 power magnification or more. I'm going to place 10 Lumineers, 10 porcelain veneers on this patient in less than 1 minute. Because I use a sapphire light. Working without the sapphire light and working with the halogen is like working with the slow speed instead of a high speed. We use the Invisalign technique for taking impressions. So it's a double wash. And what I suggest you do before you dismiss your patients is that you pour the model up first and make sure you're satisfied with it before you send it in. And you're probably, what are you putting on there? And I'm using Paint On Dental Dam, the same Paint On Dental Dam you use for chairside bleaching. The best way to protect your eyes is to close them. I give it a 3-second burst, about a ½ inch from the teeth. Your eyes. Now I'm going to start surface preparation on the enamel. First thing I do is put some etch and seal on the teeth, and it contains aluminum oxalate. And the reason for the aluminum oxalate is so when you're doing your regular operative dentistry and if you get dentin exposed, the aluminum oxalate will help seal the dental tubules and prevent sensitivity. And I just take my brush and I push it around. I like to use a medium viscosity. And we want a clean, dry surface for how long? Just long enough from the time we get surface preparation until we get that luminaire on there. So the shorter the time, the less likely we are to get contamination. Okay, here we go. And I'll just wash this off. So with tenure AB, it's not dependent on the light. It's not dependent on the brand of composite. It bonds to everything. So now we put the tenure AB on there, and we've done what? Acid etch, surface preparation with tenure AB, and several coats on. You can't put too many coats on. Now what we're going to do, this is the left central. We're going to try it in so you get a chance to look at it. In case you're wondering what this device is, this is called a LumiGrip. It was developed by another dentist by the name of Homer Meeker. And what we're going to do here is we're going to try in the Lumineer without any try-in paste and with the Ultrabond try-in paste. Now the Ultrabond try-in paste is the same as Ultrabond, but doesn't have any activator in it. These Lumineers are the same shade, B0. So why does the one on the left look different than the one on the right? It's because light, when it passes through a medium, continues forward until it hits a critical angle. But that's what you're getting on this one on the left is the appearance of the tooth where it's etched. And if you had water in there, you wouldn't get the appearance of what the Ultrabond is going to make it. So that's why you do the try-in paste. I don't like to put all the Lumineers in. They don't look that great before you bonded them. They don't look that great until you finish them. Now I'm just putting tenure S on the teeth in case you were wondering what I was doing, because that's what I use to clean the try-in paste out and off the teeth. Once you got the tenure S there, you really want to move along. Lisa does the same thing with the Ultrabond try-in paste, and you never want to do a try-in with tenure S on the teeth, because what tenure S does is it cleans everything off and it will enhance the bond and it prevents contamination. You see, a race begins between contamination and resin. Whoever gets there first wins. I need that cuspid too, because I want to get over here on that one. This is such a neat little device that Dr. Meeker put together because it's gentle. And I just carry it over and I push it down. I used to use just cotton pliers, but this seems to work out pretty well. And guys, guys. Okay. And I'm going to remove the excess around the margins. It hasn't set, so it's beginning to. I like to take the excess off and make sure on the lingual side that I have the margins filled in with the Ultrabond in the tooth, because they're all going to become one homogeneous mass. Guys. Guys. Now comes the long, dull, boring part, and that's removing the Ultrabond. And then I'm going to take about 20 minutes removing the Ultrabond. Okay. And I'm just scraping this off. Now I'm using an instrument called a Shure 349. And this is really an important one. Never use a hygienist scaling instrument because it'll scratch the porcelain. If you use a Shure 349, no matter how hard you press, you won't scratch the porcelain. And I'm ready for, here's the football-shaped diamond. Always use a copious amount of water. See, it's really simple. It's just a matter of surface preparation on the veneer, surface preparation on the tooth, and then it's a matter of bonding it, and that's a real critical phase. So I'm just blending the lingual side and the occlusal sides of the porcelain, the Ultrabond together with 4.5 power magnification. And then we'll go to the labial side and start removing the excess Ultrabond. So let's get the 12-fluted burr. And I use the 12-fluted burr first to peel away, so to speak, the Ultrabond because it's softer than the porcelain. And I stay in those interproximal embrasures and around the gingiva. And this is why you want 4 power, because he doesn't have any anesthesia. And I'm coming in here now with a 12-fluted burr. I'm trying to define the Ultrabond in the porcelain and the gingival tissue, so when I go in to take care of the gingival margin, I know when I'll be grinding on porcelain. This is a 12-fluted burr. All of these instruments I'm using are in the clinician's finishing kit, and they're very simple. Okay. I'm taking a long, narrow diamond here because it was taking me too long to get that Ultrabond out. So I'm going to still use the same process and care and diligence. Now, if I were working on a patient and the patient were anesthetized, you and I get in there and we start finishing everything off and blending it and smoothing it. And some of it is dentin. And then after the patient goes home and the anesthetic wears off, it's painful. Well, he's not going to have any pain afterwards, because if he's going to have any pain, he's going to know about it right now while I'm touching that area. And that's why I use this magnification. I owe it to my patients to not hurt them. And I don't have to give them anesthetic to mask what I'm doing to them, because I'm not doing anything uncomfortable. Now what I'm going to do is take this long ultrafine diamond and I'm going to blend the margins over your white there, okay? I'm going to blend the margins with the tooth so that the porcelain blends with the tooth the same way that enamel blends with the tooth. And this is where I take this long diamond and I'm getting into these interproximal embrasures and removing it. Because if I don't get all the Ultrabond out, it's a real tough chore trying to get through those contacts. But now I go back on the lingual side and I take a look and see if there's any Ultrabond in there to open these contacts. Because the key to the whole thing is getting out almost all of the Ultrabond. Now I'm going to go back with a football-shaped diamond. Now, we haven't opened the contacts yet, but I've got most of the Ultrabond off. So let's take a look at his occlusion. He's got a very good occlusion, but I got to look for his cuspids there. They look to me like they would. Okay, can you see that in there? Most of his contacts are on natural tooth structure. Now I'm going to give it to you in 90 seconds. Here's occlusion. No matter what your philosophy or your religion of occlusion is, it's this. That's centric. All your teeth come together, all your teeth touch. I go forward. My jaw drops. I go sideways. My jaw drops. The only time your teeth should all touch is in centric. Well, let's see what he looks like when we go into occlusion, so I can check that, because all the mistakes I've made is overlooking something. Go sideways. Toward me. That's it right there, right there. See that? Hold it right there. That's perfect. See that? Now I'm going to take a little off that cuspid, but I think I'll take it off the lower. See, that lower cuspid really likes to tear things up. So I'll shave a little off there, and I'll shave a little off here. Close. I'll go sideways. Yeah, that's much better. Okay. Can you see that on the cuspid right here? And can you see that spot right here? Okay, let's see if I can get this in here. These are prematurities that if I let the patient go home and I don't coach them a little bit about being careful, will cause them to fracture your luminaire. And so if they make a veneer that won't fracture, and you have a prematurity, what do you think will happen? You'll slowly extract that tooth. It wiggles. So it's really a very critical thing to get the occlusion right. Now close and grind around again. Like a little bit more. Okay, open. Now he's getting his, oh, look at that lateral here. See this right here? Look at that lateral on that incisal edge. See that? That's the stuff you want to look out for, because that's where the patients, especially if you go home and they want to grind them hard and knock off all this stuff, then they knock off that distal of that lateral, and it's so I just keep taking that off until we get rid of that. A few minutes spent dealing with occlusion. Open, close, grind around, open. All right, now it looks like we're in pretty good shape here, or at least he is. We're going to open these contacts. This was developed by another famous dentist, almost in the same world class as Dr. Ray Bowen. His name is Dr. Harvey Putter. He developed the Seri saw. Now we're going to go through these contacts because I removed most of the Ultrabond. Look how easy it is to get through this. And I start sanding. And if I run into resistance, then I stop and I rock. So I open all the easy contacts. And the contacts that aren't easy to open, I just stop. There we go. And that's how we open these contacts. Okay, and we're not finished, and we'll do some more finishing on this next visit. Now we're going to let you take a look, Mike.
Certainly looking at my before and after pictures, my smile is much bigger. I certainly have a more prominent smile. Because your teeth are whiter, you look a lot younger. I got comments all day about how much younger I look. And now I've got to make the appointment with the dermatologist to go in and get that done. So, you know, it's definitely one feature. You always assume that your appearance starts with your eyes and then second is your teeth. But in my case now, people are looking at my teeth first.